if you're able to copy it if anyone works or anything. If you're faster, then we are putting it on the website about the testimony and opening remarks on the website, but if you have my card, so feel free to reach out.
Good morning. I want to welcome everyone to this hearing on the Department of Health and Human Services fiscal year 2021 budget. And I certainly welcome the Deputy Secretary for the Department of HHS, Eric Hargan. Thank you for being here today. I now will yield myself 5 minutes for an opening statement. Deputy Secretary Hargan, the importance of the Department of Health and Human Services cannot be overstated. But now, amid the deadly coronavirus outbreak, the work of HHS has unmatched importance. Strategic investments in public health systems, research into a vaccine and treatments, availability of accurate testing, and access to high-quality care are critically important. But the contrast between those needs and the Trump administration's budget could not be more stark. Instead of proposing a realistic budget for HHS and taking the health and well-being of Americans seriously, the President has called for draconian cuts, mounted consistent attacks on our health care, undermined the agencies charged with keeping us safe, and starved our communities of critical resources. President Trump has proposed a nearly $10 billion cut to HHS's discretionary budget, including debilitating cuts to the CDC and NIH. He slashes mandatory health care spending by $1.6 trillion over 10 years, including a $900 billion cut to Medicaid, a $500 billion cut to Medicare, and a $200 billion cut to other health programs. The budget would require all states to enact work requirements for Medicaid enrollees, with no exceptions for pregnant women, parents, the chronically ill, and other vulnerable Americans. This comes despite the fact that no evidence exists to support the administration's claim that they increase the financial well-being of Medicaid enrollees. The administration's real goal here, it appears, is to create yet another barrier so that hundreds of thousands, if not millions, of Americans lose their Medicaid coverage, and now at the worst possible time. That's not the only way this budget makes life harder for millions of families. It includes the elimination of block grants and programs like LIHEAP that help working families fight their way out of poverty. Despite the President's promise to prioritize child care, any investments made in this budget would be nullified by the complete elimination of the Social Services Block Grant and the Community Services Block Grant, and the $21.3 billion cut to the Temporary Assistance for Needy Families program. There are other areas of the budget that don't add up either, where the message doesn't match the math. The budget includes a $716 million investment in HIV/AIDS, but cuts important NIH research programs dedicated to HIV prevention and treatment by 8%. It also cuts programs to treat global HIV/AIDS by $2 billion, or 35%. The budget requests $169 million in new resources to combat the opioid epidemic, but these nominal investments are negated by the nearly $900 billion cut to Medicaid, the source of coverage for 4 in 10 adults with opioid addiction. When you compare these small funding increases to the huge cuts that they are paired with, it's not hard to see them for what they are, token investments designed to get a good headline. If there is another explanation, Deputy Secretary Hargan, we would welcome it. We would also welcome some details on the President's so-called vision for American health care, since there are none in this budget. Nothing specific about the President's so-called commitment to lowering prescription drug prices, nothing about expanding access to affordable quality health care. It's nothing but a vague promise. There are many troubling parts of this budget, particularly since the line between massive HHS funding cuts and severe consequences for American families, between policy changes and life or death outcomes, is so direct. But look, this is not a normal budget hearing. We are potentially facing a public health crisis like we haven't seen in years, and from everything I've seen, this President doesn't get that. He sought to underfund or eliminate programs to respond to public health emergencies from the get-go. 2 years ago, he fired the government's entire pandemic response chain of command and never replaced them. He told the American people that the virus was largely contained. Then he said it will go away in April when temperatures warm up. Both aren't true. He proposed a woefully inadequate coronavirus supplemental that cannibalized other programs, playing a dangerous game of public health whack-a-mole. And the President's budget has no shortage of broken promises, harsh cuts, and cruel policies that place little importance on public health and jeopardize the health care security of millions of Americans. Our President is clearly not up to the task, but Deputy Secretary, I hope you have more to offer the American people today. I hope you were able to help reassure all of us that our government is on top of this, that the doctors and scientists who really know what they are doing are making the decisions, and that everything is being done to protect the American public. We look forward to your testimony, your response to these concerns, and getting some sort of justification for the decisions made in this budget. And with that, I yield 5 minutes to the ranking member.
I thank the chairman for holding this hearing. Thank you, Mr. Deputy Secretary, for your witness testimony here today. Today, we examine the President's budget request for the Department of Health and Human Services for fiscal 21. An important conversation, in my judgment, and one that we're having because the President, unlike my colleagues on the other side of the aisle, actually produced a budget. The primary responsibility of this committee is to put forth a budget resolution. In fact, it's required by law, yet for the second year in a row, this committee has abdicated on its responsibility. I know there will be plenty of discussion today, but I hope my colleagues will remember that political commentary won't change the important issues we need to address. With that said, let's turn to the President's budget request for HHS for this fiscal year. HHS is responsible for administering programs on which millions of Americans rely, including Medicare, Medicaid, TANF, and Head Start. You're also charged with addressing some of the country's biggest health crises, including coronavirus. The agency also faces several budgetary challenges that must be addressed: the ever-ballooning cost of prescription drugs, the solvency of the Medicare Trust Fund, the untenable spending trajectory of Medicaid. Healthcare spending is growing faster than any other sector of our economy. In 2018, the U.S. spent $3.6 trillion on health care. By 2027, healthcare spending is projected to reach nearly $6 trillion, just under 20% of America's GDP, according to a recent report from the Centers for Medicare and Medicaid Services actuary. Congress has to pay attention to the factors that are fueling this growth. First, the cost of care is increasing. According to the Bureau of Labor Statistics, in 2019, the price of hospital services increased by 3.8%, and the price of medical care increased by 5.1%, both of which are higher than the rate of inflation. Second, Americans are living longer. Thanks to advancements in modern medicine, average life expectancy has increased by roughly 9 years since Medicare was created in 1965. Now, that's good news, but it does have an impact on the growing healthcare issues facing our country. Finally, the ratio of retirees to workers is shrinking. That's not good news. An average of 10,000 baby boomers are leaving the workforce every day. Unfortunately, the laws that govern how our healthcare programs work have not kept pace with these realities. As a result, there's increasing pressure on programs like Medicare, which provides care to about 18% of our population. As an example, Medicare Part A, which covers inpatient hospital care, skilled nursing facilities, hospice, and lab tests, is expected to be insolvent by 2026, threatening the health benefits many people expect to receive in the future. That's only 6 years away. Congress and the administration have a shared responsibility to address these challenges and put our healthcare spending back on a sustainable path. I would argue that Congress and the administration not only have a shared responsibility, that's our only hope. That requires taking a hard look at what's working and what's not. It requires the fortitude to make tough choices that strengthen programs for today and tomorrow. The President's budget takes important steps to do that. It invests in the long-term health of the American people while also advancing proposals that will help rein in healthcare spending. For example, it doubles down on addressing the opioid epidemic by bolstering the SUPPORT Act, which expands across to substance use disorder prevention and treatment. Additionally, it includes new resources to expand state opioid response grants that provide direct treatment, recovery, and relapse prevention. It also supports our commitment to decreasing the number of people affected by HIV by making vital investments in programs aimed at reducing new infections by 90% within a decade. At the same time, the budget includes several common sense reforms that have been proposed by both Republicans and Democrats to make Medicare work better for patients by cutting waste, fraud, and abuse, increasing competition, and lowering drug prices and out-of-pocket costs. These comprehensive efforts are poised to achieve roughly $1.7 trillion in savings in mandatory spending. That's important progress, but with $23 trillion in debt and annual deficits over $1 trillion, there's much more work that has to be done. As I've said before, mandatory spending accounts for 70% of all federal spending today, and it's on a glide path to go to 76% by 2030. Until we make structural reforms to mandatory spending programs like Medicare, discretionary spending, including funds for defense and other key domestic priorities, and let me add, priorities that are equally important to both sides of the aisle, are going to continue to be squeezed. Congress will continue to have the same battles year after year over what programs to fund and how to handle our deficit and debt. Instead of recognizing these fiscal realities, my colleagues on the other side of the aisle continue to propose bills like Medicare for All, which would radically disrupt our health care system. So I look forward to your testimony today, Mr. Deputy Secretary. I again thank my friend from Kentucky for holding this hearing, and I yield back the balance of my time.
I thank the gentleman for his opening statement, and in the interest of time, if any other members have opening statements, you may submit those statements in writing for the record. And now, once again, I'm happy to introduce Deputy Secretary of the Department of HHS, Eric Hargan, and I yield 5 minutes to you for your opening remarks.
Thank you. Chairman Yarmouth and Ranking Member Womack, thank you again for inviting me to discuss the President's budget for HHS for fiscal year 2021. I'm honored to appear before this committee for budget testimony as Deputy Secretary for the second time, especially after the remarkable year of results that the HHS team has produced. With support from Congress, this past year we saw the number of drug overdose deaths decline for the first time in decades, another record year of generic drug approvals from FDA, and historic drops in Medicare Advantage, Medicare Part D, and exchange premiums. The President's budget aims to move toward a future where HHS programs work better for the people we serve, where our human services programs put people at the center, and where America's healthcare system is affordable, personalized, puts patients in control, and treats you like a human being, not a number. HHS has the largest discretionary budget of any non-defense department, which means that difficult decisions must be made to put discretionary spending on a sustainable path. The President's budget proposes to protect what works in our healthcare system and make it better. I'll mention 2 ways we do that. First, facilitating patient-centered markets, and second, tackling key impactable health challenges. The budget's healthcare reforms aim to put the patient at the center. It would, for instance, eliminate cost sharing for colonoscopies, a life-saving preventive service. We would reduce patients' costs and promote competition by paying the same for certain services regardless of setting. The budget endorses bipartisan, bicameral drug pricing legislation, and the overall reforms will improve Medicare and extend the life of the hospital insurance fund for at least 25 years. We propose investing $116 million in HHS's initiative to reduce maternal mortality and morbidity, to tackle America's rural health crisis, which is of particular interest to me as someone who grew up in rural Southern Illinois. We propose reforms including telehealth expansions and new flexibilities for rural hospitals. The budget increases investments to combat the opioid epidemic, including SAMHSA's state opioid response program, which we focused on providing medication-assisted treatment while working with Congress to give states flexibility to address stimulants like methamphetamines. We request $716 million for the President's initiative to end the HIV epidemic in America, which we've already begun implementing with Congress's support. The budget also reflects how seriously we take the threat of other infectious diseases, such as COVID-19. It prioritizes CDC's infectious disease programs, raising spending on them by $135 million from FY 2020 levels to $4.3 billion, and maintains $675 million in state and local preparedness funding. As of this morning, we have 78 cases of the novel coronavirus here in the United States, excluding cases that have been repatriated here. As President Trump, Vice President Pence, Secretary Azar, and all our public health leaders have emphasized, the general risk to the American public remains low, in significant part because of the President's decisive actions so far. But that, as we have emphasized repeatedly, has the potential to change quickly, and the risk can be higher for those who may have been exposed to cases here or who have been to affected areas. We are working closely with state, local, and private sector partners to prepare for the potential need to mitigate the virus's spread in the United States. As you all know, OMB has sent a request to make funding available for preparedness and response, including for therapeutics, for vaccines, personal protective equipment, state and local support, and surveillance. The President has made clear that we are open to your views on the levels of spending that may be appropriate. With Secretary Azar serving as chairman of the President's Coronavirus Task Force, we look forward to working alongside the administration's lead for the virus, Vice President Pence, to secure the necessary funding from Congress. Lastly, when it comes to human services, the budget cuts back on programs that lack proven results, while reforming programs like TANF to drive state investments in supporting work and the benefits it brings for well-being. We continue the FY 2020 investments Congress made in Head Start and child care programs, which promote children's well-being and adults' independence. This year's budget aims to protect and enhance Americans' well-being and deliver Americans a more affordable, personalized healthcare system that works better rather than just spends more. Secretary Azar and I look forward to working with this committee to make that common sense goal a reality. Thank you.
Thank you for your remarks. And as a reminder, again, members can submit written questions to be answered later in writing. And as Deputy Secretary Hargan and I discussed yesterday, there may be areas which you don't specifically have the expertise in, but you're happy to get answers from the department. So
Absolutely.
I want all the members to know that. And those questions and the answers from the department will be made part of the formal hearing record. Any members who wish to submit questions for the record may do so within 7 days. As we usually do, the ranking member and I will defer our questions until the end. And because the coronavirus has spread significantly in Washington state and reports of 9 deaths due to the virus there, this has directly affected Ms. Jayapal's district. For that reason, as a matter of courtesy, I now recognize the gentlewoman from Washington state, Ms. Jayapal, for 5 minutes.
Thank you, Mr. Chairman, and thank you, Deputy Secretary, for being with us. As you know, my home state of Washington was the first to experience a coronavirus case back in January. We're now looking at 9 deaths in the state of Washington. I am incredibly proud of our state's first responders, public health officials, and infrastructure that's been built, and the tremendous efforts and work that they have put forward. I do have to tell you that the response efforts have resulted in an estimated $200,000 a week of unexpected costs in Seattle and King County alone. People on the front lines, including health workers and emergency service personnel, were not provided with adequate personal protective equipment in advance, and the initial botched test kits and the slow response from the administration on testing protocols were incredibly detrimental to our efforts. In fact, Washington State is still waiting for half of the requested medical supplies for response efforts. Calling this a hoax, as President Trump did in the early days of this virus, was extremely damaging, and taking just $2.5 billion from other needed sources as the administration's initial response to this was simply not sufficient. Thanks to appropriators, we will hopefully have an $8 billion plus package that we will pass through the House, but it is time, Mr. Deputy Secretary, to stop playing politics with this. We are losing people's lives as a result. I want to start by asking you, is it a public health priority to ensure that anybody who is experiencing these symptoms and or has been in contact with an infected person comes to get a test?
Well, thank you for that, Congresswoman. And I just want to say my sincerest condolences go out to all the families who've lost loved ones in Washington, and our sympathies to them. Any loss of life is a tragedy. And of the 9 individuals that have passed, we know 5 were residents of a nursing home there in Washington. And also our thoughts go out to the healthcare workers in Washington, as you pointed out, the first responders, and everyone who's been
Thank you. They need the supplies, they need the tests, they need the protective equipment, but thank you for that. And if you could just...
And as for the tests, I think that for anything with regard to particularities, I want to make sure everyone goes to cdc.gov for the recommendations.
Can I just ask you to answer the question, Deputy Secretary? Is it necessary in order to prevent a public health crisis here in this country that we ensure that everybody who has experienced the symptoms or it believes to be in touch with an infected person goes in to seek testing?
I believe that...
Or public health support. Is that necessary?
I believe that, given the symptoms of the disease, and I will defer to clinicians on exactly what is done with testing. However, to repeat what our public health professionals have said, everyone, the symptoms of this disease resemble other respiratory illnesses. In many cases, people get the disease.
Is
and
it
do
a
not know
priority
they
for
have it.
people to seek care?
If people seek care many times with mild and moderate illnesses, people are recommended to stay home to treat themselves. People who need medical care should come to a healthcare facility.
So it's a priority for people who experience the symptoms that are described by CDC's protocol to come in and seek care. Is that correct?
For the level of severity that they announce. So
Thank
in
you.
other words, CDC does not say everyone who is experiencing any level of some kind of, that seems
No,
like
they've laid
severe-
out a very clear protocol and set of guidelines for those people that experience
Yeah, for
that or
those
have been
people-
in touch with infected people. Is it a priority to come in and seek care?
They should follow CDC's protocols, and local and state health authorities should consult those and look at their plans to
Okay.
make recommendations.
What about the administration's public charge rule that has created a chilling effect for people to come in and seek care? Are you telling the Department of Homeland Security and the administration that that is not helping to contain what may be an impending pandemic that would affect every American, not just those Americans who don't seek that care?
I would have to defer questions on that rule to the Department of Homeland Security.
But don't you think that's important as a public health official, the Deputy Secretary of the Department of Public Health, to ensure that people do not face those barriers if they are experiencing those protocols?
Any local decision about how someone responds and gets care is, obviously that's a matter of public health import. However, any questions about the particular rule should go to Homeland Security.
I would hope that you would let the Department of Homeland Security know that this is a public health issue for all Americans, that people do not seek care because they are afraid that they're going to be deported the next day or seen as a public charge. Mr. Deputy Secretary, some individuals have gotten tested, found that they are tested negative, and now they owe over thousands of dollars in medical bills. In a healthcare system in which 70 million people are uninsured or underinsured, and which over 500,000 people are declaring bankruptcy every year due to medical bills, what is your plan to work with insurance companies, pharmaceutical companies, and hospitals to make sure that people don't go home with bills that may bankrupt them?
We do maintain support for the ACA exchanges that provide insurance on the exchanges. We have many options and choices that are available in this country for people to finance their care. We also provide increased support to community health centers. We're very supportive of them. They provide care for many millions of Americans at reduced cost, and they're available in communities around this country.
You are aware that as the ranking member has undermined the Medicare for All bill, which would provide universal health care for everybody, the Trump administration has worked very hard to cut the care that's provided under the Affordable Care Act. I hope you're aware of that. It has serious implications now during this time of crisis for many people across my state and frankly across the country. Mr. Chairman, I know my time has yielded. I thank you for your generosity.
The gentlewoman's time has expired. Now recognize the gentleman from Ohio, Mr. Johnson, for 5 minutes.
Thank you, Mr. Chairman. I'm really actually glad to hear my colleague acknowledge the skyrocketing cost of health care, the lack of access, the number of underinsured. Thank you, Obamacare. I'm glad you acknowledged that. Mr. Chairman, thanks for today's hearing, and Mr. Hargan, thank you for coming in to address our committee today. While I'm glad we're here to discuss the President's fiscal year 2021 Department of Health and Human Services budget request, I'm frustrated that this committee has once again convened a hearing to discuss the President's budget when my Democrat colleagues refuse to produce a budget proposal of their own. It's easy to sit up here and criticize the work that's already been done, but it's the job of this committee to produce a budget, address our nation's fiscal challenges, and ensure that our government's finite resources are helping to grow the economy, create jobs, and raise wages for all. Last month, this committee held a hearing on the President's 2021 budget request, and I heard a lot of criticism from my Democrat colleagues about how the President's budget takes a wrecking ball to America's economic future and security. In fact, a senior Democrat on this committee said that the President's destructive and irrational budget intentionally goes after working families and vulnerable Americans. I can tell you, as the representative of rural eastern and southeastern Ohio, I could not disagree more. I applaud the Trump administration's proposed investments in rural America, including much-needed and overdue investments in rural broadband and telehealth services. We've seen the unemployment rate in my district decline by upwards of 60% across the spectrum of the 18 counties that I represent. It's working, and it's working for rural America. Telehealth is a powerful tool for improving access to health care for all Americans, but especially rural Americans like those that I represent. As the co-chair of the Congressional Telehealth Caucus, I've had the opportunity to witness telehealth in action in my district, whether it's robots that help seniors receive care in the comfort of their own home, or a video conferencing tool that enables stroke specialists, neurosurgeons, to consult with geographically separated doctors to give the best care possible. The opportunities are limitless and they're life-saving. And I believe we've only scratched the surface of what it can do. So, Mr. Hargan, can you tell me what HHS is currently doing to promote and expand access to telehealth services?
You're absolutely right. Thank you, Congressman, for that. Coming from rural Illinois, I understand very well what you're talking about there. Telehealth is an important aspect that we have to make sure that we expand access to it, particularly for rural and remote areas where where people aren't otherwise able to get access. Some of the things that we've done so far is that Medicare now pays providers for new communication technology-based services, like brief check-ins between patients and practitioners, and also evaluation of remote pre-recorded images and video. So now that we pay for that, the providers are going to be incentivized to actually participate in that. So that provides an incentive for them. We're also working with advanced payment models to be able to remove barriers to telehealth services within Medicare, to make sure that rural and underserved areas are getting expanded telehealth services where there's more than nominal financial risk. We also are allowing rural health clinics and federally qualified health centers, which in many cases, including my own community, are where providers, where we actually have services provided, to be distant site providers for Medicare telehealth, and makes the services as eligible payments under the Medicare physician fee schedule. So we've done all of those things. We're taking regulatory actions to be able to free up the use of telehealth in rural and remote settings.
Okay, all right, quickly, I believe telehealth could be a critical tool to help fight off the coronavirus and respond to that virus. I'm working with my colleagues on both sides of the aisle to get a provision that's in the Connect Act, Connect for Health Act, in the emergency coronavirus supplemental package, to give the HHS Secretary the authority to waive telehealth restrictions during national emergencies, which could help prevent a run on the healthcare system, especially in rural America. So, Mr. Hargan, do you believe that waiving telehealth restrictions during national emergencies would benefit how HHS and the administration combat the outbreak of coronavirus?
I believe that could be, providing greater access to telehealth in situations can be a tremendous help, especially because it helps relieve congestion on what could be overburdened local healthcare systems, and allows patients to be at home, isolated in certain circumstances, and still have access to professional care. So I think it's very important. We would love to work with you all to provide technical assistance, whatever else you need to be able to work through issues like that.
Well, we're working to get it in the supplemental. I hope my colleagues on the other side of the aisle will join us and try to get that done. Thank you, Mr. Chairman. I yield back.
Sounds like a good idea. I will say to my colleague from Ohio.
Thank you.
The gentleman's time has expired. Now recognize the vice chairman of the committee, the gentleman from Massachusetts, Mr. Moulton, for 5 minutes.
Thank you. Mr. Chairman, it's remarkable that my colleague across the other aisle, after 5 concerted minutes of a real decent back and forth between the deputy secretary and the representative of a district who has lost men and women, good Americans, to coronavirus, that he had to start with a partisan attack on Medicare for all. I don't personally support Medicare for all, but I certainly support the principle that we should be expanding healthcare access to Americans. And you know what? Healthcare budgets are going up because our population is growing. And we want to have more Americans get good healthcare.
Would the gentleman yield?
Deputy Secretary, I appreciate your seriousness with which you are approaching both the coronavirus and your broader duties. Because, look, there's been a lot of partisan talking points thrown about. I understand that the Trump administration is no more responsible for the coronavirus than coronas. But the Trump administration and your institution in particular is responsible for preparing for diseases and pandemics, for responding to them, and for keeping Americans healthy. So I have a number of questions. Deputy Secretary Hargan, would you or your boss like to revise your FY21 budget request for the Infectious Disease Rapid Response Reserve Fund or the National Institute of Allergy Infectious Diseases?
I think that whatever obviously, the President has indicated willingness to work with revisions to the supplemental request, and I think we're going to engage on all fronts in deciding exactly how the money should be apportioned.
Well, I hope that's a yes, because your budget cuts CDC's Infectious Disease Rapid Response Fund by $35 million, a pattern that dates back to a request of exactly $0 for FY19. Would underfunding an account in FY21 that's already been tapped this year for coronavirus help our response?
I think we've asked for $135 million more.
So I assume no,
infectious disease
because you've asked for more, which I appreciate. Your budget request also reduces NIH's National Institute of Allergy and Infectious Diseases funding to levels below that which was appropriated in FY19 and FY20. Will this improve our ability to conduct and support research on the coronavirus or other outbreaks?
I think that we will engage on the supplemental to decide exactly what portion.
Right, but will your cut improve our response?
CDC. Well, I think we have advocated for at least $2.5 billion more dedicated to the corona response in the supplemental request.
Well, I'm glad to hear that, frankly, you have the courage to disagree with the President's budget request. I appreciate that, because it shows that you and the professionals at HHS are doing their job. When President Trump announced that Vice President Pence would be his coronavirus czar, he declared that the risk of coronavirus to the American public, quote, remains very low. Vice President Pence echoed this concern. Now, the World Health Organization, on the other hand, has warned that coronavirus could be classified as a global pandemic in the near future, if not today. Is WHO wrong when it signals potentially elevating the classification of COVID-19?
WHO has its own responsibilities and its nomenclature, and it's responsible for declaring whether something is, under their view, a pandemic or not.
So do you think they're right or wrong?
We will do exactly what the response is that we need for the American people, regardless of what the WHO says.
I understand that.
Or how they declare
I understand that, but do you think that they're right or wrong?
I don't intend to oversee their operations of the World Health Organization. Whatever they decide in terms of their nomenclature.
So do you think this is a pandemic or not, Deputy Secretary?
I believe that the WHO has its own responsibility for that nomenclature.
Do you think that this is a pandemic or not?
WHO has its own.
No, we'll take WHO out of it. Do you think that this is a pandemic or not?
I believe that whatever we do within the U.S. government at HHS is the important thing that we focus on. It's providing responses.
Just answer the question, Deputy Secretary. Is this a pandemic? The American people want to know, and they deserve to know, and they deserve to hear it from you.
With response to the declaration of these kinds of terms by the WHO, I defer to them.
No, I'm not talking about the WHO. I'm talking about you and HHS. Is this a pandemic?
The declaration of a pandemic or not, from an American point of view, from an HHS point of view, doesn't...
One more quick question. The President said that we're very close to having a vaccine. Is that true? Are we very close?
I think Dr. Fauci has said that we're within 2 to 3 months, hopefully, of entering a
2 to 3 months. So we're going to hold you to that, Deputy Secretary. 2 to 3 months for a vaccine. Thank you, Mr. Chairman. I yield back.
Trials. So I just echo what Dr. Fauci said in his testimony.
You can go ahead and finish your answer.
Yeah, so he had said within 2 to 3 months they hope to have a vaccine, candidate vaccine, into clinical trials, and after then we would enter into further phases of the vaccine after that in terms of preparation.
So when can Americans get the vaccine? What's your estimate?
I think we will see what the scientists, the laboratories, and the researchers are able to achieve. But we think that, I think according to what we've been told most recently, we're going to hopefully have a vaccine earlier than we have had vaccines in the past because of the investments that have been made by Congress, by the administration over the past years in order to prepare us for situations like this.
Gentleman's time has expired. I now recognize the gentleman from Missouri, Mr. Smith, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Secretary, for being here. There's so many things that I would like to ask or even to comment on. We are here in regards to you presenting the president's budget. And so let's just get some facts out there quickly. And that is, the president presented a budget this year. That's why you're here. The House Majority Democrats have not presented a budget this year. Last year, President Trump presented a budget. Guess what? The House Democrats didn't present a budget. They like to criticize the president's budget. They like to criticize the budget that you helped with, but they can't even present a budget themselves. And just like Speaker Pelosi has said numerous times, a budget is a statement of your values. The reason why the Democrats can't present a budget on this committee is because they can't get along. Because more than a half of the Democrats on this committee are sponsors of Medicare for All. More than half of them are. The cost of Medicare for All is over $30 trillion. That's their solution to health care, Mr. Secretary. Medicare for All. That would cost every household $25,000. Think about that. That's why they don't have a budget, because they can't decide whether to put that in there or not. I'm thankful that you're here, at least presenting a budget. I'm also thankful that the Republicans, over the last several years, have increased NIH funding by 39%. I'm also thankful that Republicans have increased funding to CDC by over 24% in the last several years. I'm also thankful that the president has signed legislation in the last year to help make us better prepared for possible outbreaks like the coronavirus. However, unfortunately, what I'm not thankful for is hearing so many folks on the other side of the aisle try to make coronavirus political because they hate the president. We've had Democrats that has called coronavirus the Trump virus. That's unacceptable. It's unacceptable. Sunday, when I was home in my congressional district, 14-year-old girl died of the flu in my hometown of 5,000 people. A 14-year-old girl. 9 people have lost their lives by coronavirus in the state of Washington. 15 people have lost their lives from flu in my congressional district this year. A loss of a life is horrible. We have a vaccine for flu. We don't have a vaccine for coronavirus, and still people are dying. We have the best health care in this country than any other country in the world. And I know that Americans can pull together and make a difference. And a lot of us don't know how bad coronavirus is. People may act like they do, but they don't. We do know flu's bad. A lot of people's losing their lives. I just gave you the number of how many have lost their lives in my congressional district alone, which is almost double of how many has lost their lives of coronavirus so far. What's unacceptable is the Democrats have been playing partisan games with coronavirus. They complained when the president asked for an increase of funding and a supplemental of $2.5 billion because they said it wasn't enough and that we needed it fast. Guess what? 10 days ago, the president asked for that funding, and we are still waiting for a supplemental bill to be filed by the House Democrats. They say they need more money. Last week, instead of doing a supplemental bill, we banned flavored cigarettes. Let's get our act together. The Democrats control this House. Let's put a supplemental on the floor and at least file a supplemental. I would love to see what's in it. 10 days. How many days is it going to be? Or is it going to be filed today? Or is it going to be a couple weeks? I yield back, Mr. Chairman.
Gentleman's time has expired. He'll have it before the end of the day, actually. Now yield 5 minutes to the gentleman from New York, Mr. Higgins.
Thank you, Mr. Chairman. I would agree that we're here to discuss budget facts, so let's talk budget facts. The budget proposes to cut $1 trillion to Medicaid, which will hurt access to about 13 million Americans. The budget proposes to cut about $500 billion to Medicare. The administration has said in relation to these cuts that the president's budget is not an action item, it's a statement of priorities. In your biography here, Mr. Secretary, it states that as Deputy Secretary, you're the Chief Operating Officer and are responsible for overseeing the day-to-day operations and management of the department, in addition to leading policy and strategy development. Are these cuts representative of the president and your priorities?
Before you answer, Deputy Secretary, could you pull the microphone closer to you? Or move closer to it? Apparently, people are having trouble listening on C-SPAN.
Sure. So with regard to Medicare and Medicaid, which I think you were mentioning, there is no cut year to year in the money spent on either of these programs. In fact, our budget anticipates a growth in the programs every single year, Medicare and Medicaid for the entire time, the next 10 years. So there are no actual cuts here at all. In fact, what we are trying to do is slow the growth of these programs, we hope in a thoughtful way. For example, in Medicaid, we took projected growth of spending from 5.4% to 3.1%. Now that means that it would be roughly in line with the average salary increase that Americans are projected to have. With regard to Medicare, it's from 7.3% growth to 6.3% growth. So we are anticipating growth in these programs, but we are trying to make sure that we are saving these programs in a sustainable way into the future. We know that the Medicare trustees have told us, as we heard earlier, 2026 is a time in which the trust fund will start to run out. The reforms that we proposed will extend the life of that trust fund to 25 years at least, and I think we have to preserve it not just for today's seniors, but for tomorrow's. It's a promise to the American people.
Mr. Secretary, respectfully, the cut is explained in the budget detail that it would be a cut to providers, but those are the very providers that we depend on to provide access to those under the Medicare program. So a cut to those providers will likely result in limited access to those providers. Also in the budget, the National Institutes of Health, which is a very, very important research institution, the largest research institution in the entire world. It includes many component parts that are important to us. The National Cancer Institute, the National Institute for Allergy and Infectious Diseases. There are cuts to these two agencies as well. Does this represent a statement of priorities for the President and you as Secretary?
Well, within the discretionary budget, NIH is and remains the single largest item that we're proposing in our budget. So in terms of the priorities that this administration has for its budget at HHS, NIH is our top priority. So it remains our number one spending item in the discretionary budget. So whether it's as a statement of values or just as a matter of fact, we're proposing that NIH remains the number one discretionary spending
So
item.
if it's the number one priority, why is it proposed to be cut?
Within the discretionary budget environment that we're in here, that NIH funding has been increasing at a rate that I think it's hard for our budgets to keep up with. We're trying to reduce federal deficits and debt. And now I think Congress, of course, is going to decide the right spending level.
Final
for
question,
NIH.
Mr. Secretary. The President said earlier this year that, quote, I was the person who saved pre-existing conditions in your health care. The fact of the matter is people with pre-existing conditions have insurance because President Obama's health care law. which the president, President Trump, is now trying to obliterate through the federal court. There's only, before the Affordable Care Act, if you had a kid that was stuck with childhood cancer, an insurance company could deny you coverage because of a pre-existing condition. You can't do that anymore. It's against the law. But there's only one law in America that protects people with pre-existing conditions, and it's the Affordable Care Act. So if you're trying to obliterate that law with a specific alternative to replace it, you don't support protecting people with pre-existing conditions. I'm just curious, how do you reconcile that, sir?
Oh, you may answer.
So with regard to that, as you know, the president has said that is the centerpiece of whatever reform we would bring forward, and is to protect Americans with pre-existing conditions. And so we reiterate that as the centerpiece of that. Regardless of if Congress has some reforms in mind for existing laws, we would endeavor to make sure that protection for pre-existing conditions is at the center of it, regardless of what form that takes.
Gentleman's time has expired. I now recognize the gentleman from North Carolina, Mr. Holding, for 5 minutes.
Mr. Secretary, various national regulatory authorities take different approaches to overseeing the manufacture of drug products, and this is true even among countries that are part of the International Conference of Harmonization, which produces guidelines tend to streamline global regulations. And additionally, regions and countries with regulatory authorities that diverge from the ICH completely may contribute to global risk for drug supply interruptions by diverting manufacturer time and attention away from establishing quality measures. So my question to you is, how has the FDA worked with the International Conference for Harmonization and the Chinese government, which is part of the ICH, to align on current good manufacturing practices standards, and what is the impact of streamlining these standards on the cost of drug products?
Yeah, thank you. And as I'm sure you know, that in 2008, FDA established its first foreign office in Beijing to promote international policy harmonization in terms of regulating drugs that are coming into the American market from China. So between harmonization and regulatory convergence, we have a China office there. It's currently working with local drug manufacturers on quality improvement, and that's going to we believe that's going to help facilitate first cycle approval of generic drugs, which is consistent with the FDA's goals overall and the record numbers of generic drugs that have been approved each of the last 3 years. Now, since June of 2018, China has been involved with the International Council of Harmonization. They have been nominated to join the management committee. Now that gives us great hope that if China is part of the ICH in a thorough way, that they're going to join in those harmonization efforts, and we're going to be able to help facilitate their entrance into joining international standards, which FDA and others of our peer countries have been working for years on trying to harmonize the regulatory structure and making sure that drugs produced anywhere are going to have the highest level of quality. So what we've been able to see is that they are attending meetings, we're having conversations, sending technical experts to these international forums. Now, the ICH, we believe, has kept pace. The membership criteria for them is robust. So China, to get entrance into that, is going to have to implement a basic set of regulatory requirements for the manufacture of pharmaceuticals, for the conduct of clinical trials in China, and for stability testing of pharmaceutical products. So with their entrance, they have to hit those requirements. And so, we're looking forward to seeing how that is accomplished, which will accomplish greater quality improvements on things sourced in China.
Good, thank you. Now, I've been encouraged by the administration's effort to improve treatment for ESRD patients through the 2019 executive order advancing American Kidney Health Initiative, as well as the ESRD treatment choice model proposed last year, aimed at providing patients more choices through moving to dialysis at home or a transplant. Kidney disease has a significant impact, as you know, on Americans' everyday lives and makes up more than $1 in $5 spent by the traditional Medicare program. So my question, Mr. Secretary, is do you anticipate that you finalize the ETC model in the next few months, and can you speak to the savings that this model is expected to generate?
Yeah, we are working internally on that model, as you know, right now. So we're while I don't want to perhaps give any particular timing on that, it is obviously kidney health is a serious priority for the president. As you point out, it's about 20% of the spending in some of our programs at HHS, and it's a serious, not just a financial, but a physical drain on people who are in dialysis treatments. So we are working to stand that out. These are sort of, these issues, as you know, go back decades with regards to how we treat and reimburse patients in this area. In many cases, it has been, I think, a galvanizing moment for this part of the healthcare sector that we have new models being proposed. So we hope to have something out, as I say, as soon as we can, making sure that we get a thoughtful and successful launch of a model.
Thank you. I have another question which I'll submit for the record regarding the Pharmaceutical Cooperation Inspection Scheme and the Mutual Recognition Agreement with the European Union and the Australia, Canada, Singapore, Switzerland Consortium, but I'll send that to you in writing as I'm out of time. Thank you, Mr. Chairman.
Thank you. The gentleman's time has expired. Now recognize the gentleman from New York, Mr. Morelli, for 5 minutes.
Thank you, Mr. Chairman, very much for holding this important hearing today, and thank you, Deputy Secretary, for, I know it's hard to find where we are, right? Yes. Thank you, I'm over here. And thank you, Deputy Secretary Hargan, for being here. Mr. Secretary, as you may be aware, in November of last year, the Department of Health and Human Services denied the state of New York's request to renew its delivery system reform incentive payment, called DSRIP for short. It had a waiver. We wanted to extend it past March, and that's been denied. DSRIP is a Medicaid redesign program dedicated to fundamentally restructuring the healthcare delivery system by reinvesting in the Medicaid program with the primary goal of reducing avoidable hospital use by 25% over 5 years. So the idea is, rather than using sort of a slash and burn technique to cut healthcare costs, DSRIP provides a comprehensive and sustainable approach that takes preventive measures to identify the needs of our most vulnerable population before treatment becomes incredibly costly, and much of that involves the social determinants of health. For example, suffering from congestive heart failure is expensive, obviously frightening, and requires regular medical attention. If you add to that the question of stable housing for the patient, and you add that into the equation, you're really now dealing not only with extensive concerns that you might have about your health, but you're also having to do it while you're worrying about whether you have a roof over your head, working to keep food on your table, paying for prescription drugs, et cetera, and simply getting to a doctor's appointment becomes both a physical and emotional and financial drain and challenge. So, and you're forced not to choose simply between your immediate stability, but also your long-term health and the cruel and unsustainable situation that it puts people in. So DSRIP funds programs that New Yorkers and patients throughout the country who have complex medical issues, allows them to address those needs. The dollars were allowed under the federal waiver to assist people with complex affordable housing issues, arranged medical transportation, and dealt with things like opioid addiction, childhood asthma, a whole host of programs and projects that were undertaken by the various DSRIP provider networks throughout the state. Since the implementation of it, hospital admissions have been reduced by 21% among the Medicaid population that was targeted, and preventable readmissions reduced by 17%, according to the numbers that I have from June of 2018, the last data that's available. This budget cuts Medicaid. It stops the waiver program, and in effect, in my mind, while you can get short-term gains, perhaps in terms of financial gains, the outcomes are going to be dramatically reduced, and in fact, cost us long-term far more money. Money the people in the healthcare field are often trying to get to the quadruple aim, which is better outcomes, bending the cost curve down, having improved patient experience and improved provider experience. And I am very, very troubled that this budget doesn't take into account many of the advances that are made towards achieving the quadruple aim and using social determinants to achieve better outcomes. And I want to know whether or not the department would reconsider New York's disrupt waiver application.
With regard to the particular waiver application, we can certainly talk to you after this, but I wanted to talk a little bit about social determinants of health. I think we completely agree that these are issues that we have tried to stand out on in terms of developing thoughtful policies dealing with those. We know that in many cases they can be very helpful to people and can help avoid some of the hospitalizations, some of the further medical problems that take place down the line, that there are, and some of the flexibilities that we've tried to allow people to have in spaces for plans to be able to work them into their own plans, we think is very helpful. Some of the things like the Stark and anti-kickback reforms that have been proposed would allow social determinants of health to be worked on among there. So some of the regulatory reforms are very much aimed in that direction.
Well, let me, I appreciate that. I would suggest this, and I apologize because I only have just a few seconds left, and this is probably less in the form of a question than just a comment on it. I would suggest that in the short term, the next 36 months, that we would have to make significant new investments in Medicare and Medicaid to have real redesign of systems that allow for the longer term changing of the cost curve down and improving those outcomes dramatically. And I would like to work with the department on thoughtful ways to increase investments to have longer term savings, again, improve outcomes, avoid admissions, avoid readmissions, and improve patient experience and those of providers who are struggling under shortages to deal with the stresses of their jobs. So I appreciate you being here, and I'd like to continue the conversation if we can offline. Thank you, Mr. Chairman.
Gentleman's time has expired. Now recognize the gentleman from South Carolina, Mr. Norman, for 5 minutes.
Thank you, Chairman Yarmouth. Mr. Secretary, thank you for coming. Before I ask my question, I'd like to yield 60 seconds to Congressman Stewart.
Thank you, Mr. Norman, and I won't take 60 seconds. Being respectful of your time, Mr. Deputy Secretary, thank you for being here. I did have a question, but many of us are trying to deconflict schedules here, and I can't stay. There's a company in my district called Navigen. I'm aware of other companies as well that think they have solutions or partial solutions or potential solutions regarding the coronavirus, and I'm sure you're aware of some of these. What I'd like to do is just submit in writing for the record the agency's plan to develop and to leverage these public-private partnerships. Very clearly, the answer is going to come from some private company somewhere. Do we have a highway, a way of integrating with these companies and to get the information from them that otherwise, in a very time-sensitive manner? And again, we'll submit that for the record.
Yep.
Thank you, Mr. Norman.
May I ask the gentleman, you have something you want submitted for the record?
Yes,
Okay.
if we could.
I couldn't quite figure out whether you wanted him to submit something in response to you.
If I misspoke, I apologize.
That's right. Without objection, so ordered. Thank you. Thanks.
Deputy Secretary, one of the most frequent calls I get is pricing for pharmaceuticals. Why is my insulin price so high? Why is a particular type drug? What PBMs are a great interest to me. The spread pricing that where they reimburse pharmacies one price, charge the state astronomically higher price. Can you give me a roadmap for what you consider a way to bring the light to that to help our consumers?
Well, as you know, the president has made bringing down the cost of pharmaceuticals one of the keystones of what we're trying to do at HHS, and put out early on in Secretary Azar's tenure, we put out a blueprint addressing drug pricing, which had dozens of different proposals that were standing out in terms of addressing drug pricing. Some of the things that we have done, one of the things that we've done just internally at the department is the fact that the generic drug approval rate has gone up to record levels. We've also had high numbers of innovator drugs that have been approved. All of those things, just kind of their nature, by producing competition, produce lower costs for Americans. So we've seen drug prices, and Americans use generics in large numbers. So we've seen prices lower as more generics come online. That's a huge help, and that just happens in the day-to-day business of the department, but now at record numbers, thanks to some of the reforms that were put in place. On top of that, we have other proposals, things like the direct-to-consumer rule that has been put out that shows people the prices that they're going to be charged. We think that would have some effect on drug prices as well. We also are very happy to engage on drug pricing proposals that Congress has put forward to move forward on a bipartisan, bicameral basis to have legislation that can enable Americans to get lower prices for drugs. We've endorsed a number of different areas in that space. However, we know that Congress has a lot of different potential proposals in here, and we would be happy to work with people here on that basis to bring forward good legislation in this area.
I appreciate it. You know, when you get calls from those widows whose child's been diagnosed with diabetes, and the question is, how can I afford the insulin because the alternative of her dying, it has an impact on you.
Yes.
So, and I appreciate the administration's goal to keep the focus on that, and it's real, I can tell you, in the real world.
Yes, absolutely. And, you know, we have done some reforms. Part D premiums have come down over 13% in the past few years. So you're seeing the impact in areas on there. That doesn't mean that we stop just because we have had some successes in bringing down premiums and bringing down prices. We still have areas where we need to focus. And, you know, insulin is one of the areas that we hear a lot of public testimony on that very issue. So we are committed to working with Congress on these issues.
Well, I appreciate it. And insulin is one. The question I had from the person who called me was, people have had diabetes for a long time. Why is a drug that should be a lot cheaper than it is, why am I having to pay the price that I am? I got 30 seconds. What about, I've got a lot of rural communities and with sovereign Indian tribes, access to health care. What is your take on that, opinion on getting them easily accessible medical care?
So with regard to rural areas, we have a lot of different proposals. The Secretary about a little over a year ago put together a rural health task force internally at the department. And so we have been working to get together a package of proposals to work on with regard to rural health. So expanding access in there is going to take both the areas technologically, like telehealth, which we've talked about already, but also being able to have a good workforce in the area where people can practice to the top of their license, and we have access to care, both on the service side as well as the technological side. Both of those areas are going to require reform. Some of it's going to require reimbursement reform, and we've advocated for some of that and have enacted some of that. But it's going to require probably a longer conversation. 57 million Americans live in rural areas. There's a disparity between rural America and non-rural America in terms of the health care that they get on basic things like heart disease and cancer. And we're going to have to move to a model that's going to enable rural Americans, like myself, as I grew up, to have access to care, to have access to quality care that they deserve. And some of that is going to be, as I say, technological. Some of it's going to be workforce development that's going to enable us to move forward into a new model of rural health care that's going to allow Americans to get better care.
Thank you for your service.
Gentleman's time has expired. Now recognize the gentleman from Nevada, Mr. Horsford, for 5 minutes.
Thank you very much, Mr. Chairman, and thank you, Deputy Secretary, for being here today. I want to point out just before I begin, several of my colleagues throughout this morning have talked about the budget and the President's budget proposal, the congressional budget. But I just want to reiterate that there are budget cap agreements in place through 2021 that have been agreed to with the Senate, with the House, and the administration. In fact, the ranking member of this committee and many members on the other side voted for those budget caps. So I know we get a lot of misinformation from the White House, but I just wish that we would not bring that misinformation into this committee setting. Mr. Deputy Secretary, last week your boss, Secretary Azar, came before the Ways and Means Committee, and I asked him about the administration's proposed $52 billion cut to the graduate medical education program. Today, these cuts would have detrimental impacts on my home state of Nevada, where we need more physicians, not drastic cuts to the very program that trains and retains our doctors, particularly in this environment with the coronavirus where some of our doctors who are being exposed are no longer available. So my question to you specifically related to this is, Nevada ranks 48th in the nation for primary care doctors. We have about 180 full-time doctors in Southern Nevada per 100,000 compared to over 303 on average. And in certain parts of my district, I literally don't have adequate number of OBGYN providers. We have 259 in the entire state of Nevada. So what is your take on the proposed $52 billion of cuts to the GME program?
Well, I think that the point that you made about the lack of OBs, for example, my parents are, and I'm from Southern Illinois, but I was born in Missouri because there wasn't even an OB available in rural Southern Illinois at that time. So
why is the administration cutting the very program that trains more doctors, including OBGYNs?
One thing that we've done is by turning this into a more flexible block for GME, we've incorporated a lot of the GME money into a single program. That's going to allow
reclaiming my time, because that's the exact statement that the secretary gave me in the other committee, and somehow he argued that cuts to a critical training program would be good for states like mine, and that simply is not true. Not only would my state lose funding for new doctors under this budget, the plan outlined in your budget would hurt the 630,000 Nevadans who are covered by Medicaid. Both the American Academy of Family Physicians and the American Medical Association put out statements opposing the administration's proposal and have warned that it would lead to significant benefit cuts, would require states to limit the number of beneficiaries receiving coverage, and it would put vulnerable populations at greater risk. We are a growing state. Putting us into a block grant program and calling it flexibility doesn't work. So I am unclear, how does a proposed flexible fund, which is just a block grant program and which adds no additional funds to the training of doctors in my state or any others, how does that help constituents have access to more doctors?
So when you talk about exactly what GME has done so far, we haven't had a real revision of this law in terms of like what types of doctors that it funds since, I believe, 1996.
So will you work with us on that to address the need to diversify the revenue that funds the GME program so that we're not just relying on CMS funding?
And yeah, I would say that one thing that we're trying to do here in the reform is to move it out of being funded by the Medicare Trust Fund, which we think is a place where seniors are actually using some of the Medicare money that's been set aside for them to fund GME, which in many cases funds doctors that aren't actually
So you agree to
Medicare
work
doctors.
with us to come up with a more robust GME program so that we can train more people and meet the needs of our constituents that need to see doctors?
And update the GME program so it
that a yes?
represents
Is
today.
that you?
Yeah, we would love to
Great.
work with you.
The administration also proposes a nearly $1 trillion cut to Medicaid over 10 years. How will these compounded cuts impact my constituents' ability to lead healthier lives and access physicians that they need?
We think there won't be any cuts to Medicaid at all. Every year there will be an increase in payments in Medicaid. We anticipate all that we're doing here is putting in place reforms that are going to slow down the rate of growth to make
Slow
sure
down
it's a
the rate
sustainable
of growth.
program.
In effect, cuts $1 trillion over 10 years. Let's be honest with what it does. We get a lot of disinformation and misinformation. Let's not continue to do that in this committee. Thank you, Mr. Chairman, and I yield back.
Gentleman's time has expired. Now recognize the gentleman from Tennessee, Mr. Burchett, for 5 minutes.
Thank you, Mr. Chairman, Mr. Ranking Member. Although our ranking member has decreased in age, he has not increased in good looks, and I'd like to state that for the record. Thank you, Mr. Hargan, for being here today. And I would like to ask about focus on Medicaid. This is today in Tennessee. Do you think Washington or state governments are better equipped to design programs that are best suited to their individual state?
The states. Obviously, that's the whole promise of the Medicaid program, is that the states run the programs for their own populations.
Great. As you know, my home state of Tennessee is the first state to convert our current Medicaid program, TennCare, into a block grant.
what would the impact of this budget have on this new direction my state is going?
Well, we are, I know, working with Tennessee on their proposal and what they have done. And again, Medicaid rises every year. The amount of money that is set aside for Medicaid in this budget goes up every year. So we would anticipate that the money would go up for Tennessee, and that those flexibilities that would be available under any proposal are there for Tennessee for its own population and for the needs that they see locally for their state.
Okay. I have no more questions, Mr. Chairman. I will yield back the remainder of my 3 minutes and 32 seconds.
Thank you, sir.
You're welcome,
I
sir.
won't even say your time has expired. You yielded it back. I now yield 5 minutes to the gentlewoman from Illinois, Ms. Chakowski.
Thank you, Mr. Chairman. Deputy Secretary Hargan, when President Trump ran for office, he made a promise. He said, I'm not going to cut Social Security like every other Republican, and I'm not going to cut Medicare or Medicaid. However, in almost every one of the budgets that he has released since taking office, he has proposed slashing hundreds of billions of dollars from Medicaid and Medicare and Social Security. For fiscal year 2001, you have proposed cuts of $500 billion from Medicare, almost $1 trillion from Medicaid, $25 billion from Social Security. These programs keep seniors, individuals with disabilities, and their families alive. And they are critical as we battle coronavirus right now. Medicaid covers the care of 6 in 10 nursing home residents who are often older and living with chronic medical conditions, putting them at high risk, as we've seen in Washington State. While your administration recently requested $1.2 billion in new resources to fight coronavirus, the supplemental request did not address $900 billion in cuts to Medicaid as was in the original proposal. So you may say that you were unaware of the coronavirus and scope when you wrote that budget, but clearly we have a problem right now. So what steps or policies are you taking to reduce the spread of coronavirus among nursing home patients, which is a boiling question right now, or other vulnerable populations who live in congregate residence setting?
Thank you, Congresswoman. We are, right now, as Dr. Schuckett of CDC mentioned, Administrator Verma, who oversees nursing homes, has appointed a liaison to work with CDC to make sure that CDC's practices into nursing homes are brought directly into CMS. So they're working closely on the issue about nursing homes. As we had seen from Washington State, that's an issue of the highest priority. Because the disease, from what we have seen so far, really afflicts particularly those who are both elderly and medically frail. That's why we need to make sure we focus on that, as Dr. Fauci said.
So are you regretting, I hope, that this almost $1 trillion cut in Medicaid at this very moment, when 6 out of 10 people in nursing homes require help from Medicaid?
Well, there are no cuts to Medicaid in the budget. Every year, the money for the dollars to Medicaid go up every year in this budget. Same for Medicare. We are simply talking about decreasing the rate of growth to an amount that the average American's wages go up every year, as we expect. So if we reduce those, what we're doing is preserving it for future Americans. The Medicare trustees tell us the Medicare Trust Fund is going to start running out of money in 2026.
Talking about Medicaid, let me finally, over the past 2 weeks, I urged Secretary Azar, by a letter that was signed by 45 other members, to ensure that the coronavirus vaccine or treatments that may be found will be affordable, accessible, and available. And just yesterday, President Trump met with a group of pharmaceutical executives. And so I'm wondering, do you have any update on the arrangements that have been made with the pharmaceutical corporations and other private sector partners around licensing and pricing of the COVID-19 vaccine?
Well, as you point out, we are working with the private sector to develop and test COVID-19 vaccine. Government scientists invented some of the vaccine's critical aspects, and we intend to work with the companies to ensure that the price they charge the government for the vaccine is affordable for taxpayers and patients as well.
Thank you, and I yield back.
Gentlewoman's time has expired, and now recognize the gentleman from Pennsylvania, Mr. Muser, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Deputy Secretary Hargan, for being with us. I represent a relatively rural congressional district, and I have concerns related to CMS's so-called competitive bidding program, particularly related to rural areas. CMS issued an interim final rule in May of 2018 that provided payment relief for durable medical equipment in rural areas and has continued the relief until the end of 2020. Mr. Secretary, can you tell me if CMS plans to continue this relief in rural areas after 2020?
Well, we do know that we are in the bidding process right now for the competitive bidding program, and that we, as you pointed out with the IFR that was issued, there was some granting of relief by the agency on that. We are hoping that this is going to alleviate a lot of the problems that are faced by suppliers in that area. We do know that there are issues in rural areas where the number of suppliers continues to decline in that space, which creates particular issues for competitive bidding in rural areas. So I think we look forward, we're going to be continuing to work in this area to figure out how to come up with solutions for rural areas that have declining numbers of providers in this area of DME.
Well, that's excellent to hear. I spent quite a number of years in the home medical equipment industry, and I feel, as many do, and I think stakeholder groups, consumer groups, that very often competitive bidding is very much of a misnomer. It's really more of the lowest price regardless of quality, patient choice, who the supplier might be, provider or supplier standards, and distance to travel usually is not often enough taken into consideration. So when and it sounds like you know a thing or two about it, which is encouraging. Before any such decisions are made, you do plan on having stakeholder input?
So with regard to winding CMS and issues like this, it's definitely being considered by the Rural Health Task Force that we've drawn together that looks at sort of rural health and the problems that are faced by it from the point of view of all of our agencies, including CMS, including HRSA, the Indian Health Service, and others that deal with the issues of getting rural access to care. So DME is one of those issues. Obviously, CMS has taken action on this to provide relief, but we're looking forward to getting a comprehensive package of reforms together in this area and getting them out.
Again, very encouraging. That's good to hear. In the 2021 budget, there's a provision that would expand the competitive bidding program for DME into rural areas in 2024. Is this something that you believe CMS plans to move forward with without congressional approval? Can you tell me anything more about that?
So I think as of now, we're planning on basing competition on the rural areas rather than on urban areas, which we think is probably better representative of what the conditions are in those areas. So we think that has attempted to de-link in some ways the competition from areas that probably were inadvertently providing issues for rural areas. So, but we would look forward to further engagement from the community on this as we move forward, as I say, with an overall package on rural healthcare reform.
Thank you, Secretary. Mr. Chairman, I yield back.
Gentleman yields back. And now, you ready? I now recognize the gentlewoman from Texas, Ms. Jackson Lee, for 5 minutes.
Mr. Chairman, thank you. Thank you very much, and to the Deputy Secretary, appreciate you being here. Just came from the airport in light of some civic responsibilities on Super Tuesday. And so I am just coming from home where people are grappling with the coronavirus. I think you're well aware of what people who are beyond the Beltway are thinking. I want to ask specifically the issue of your proposal originally to cut CDC's discretionary budget by nearly 1/5 and its overall budget by 9%, or $700 million. If enacted, how would these cuts affect the CDC's ability to respond to the future global epidemics? Now, let me say that I know that budgets are prepared over a long period of time, but I also know that it was not finalized before there was an indication that there was a major epidemic in China. And I'm baffled how the administration could send forward a budget that would do such drastic things. I also want to, let me match this question of how did the HHS, so these are two together, determine that that amount was sufficient, the $1.25 billion was sufficient to fully address the scale and seriousness of the coronavirus epidemic? And what activities would HHS not be able to carry out if that $535 million were repurposed?
Thank you for that. The cuts that you talked about that were indicated, we actually increased the funding for infectious disease response at CDC by $135 million. So we had actually already increased funding for these specific areas in the budget that was proposed. So CDC's funding would go up this year.
But only in the infectious diseases area.
And that's the area that we would use for the coronavirus
Right,
issue.
but that's not all that they do. I did ask a specific question. Go ahead, let you finish.
And with regard to the $2.5 billion supplemental that was brought forward last week by the administration, we, as the President said, we are open to discussions with Congress about this. I think he said very specifically about that. So with regard to the number that Congress proposes on that, we're absolutely willing to work with you all flexibly on that front.
Mr. Deputy Secretary, with all due respect, don't you think it was somewhat derelict for the administration even to think about reducing funding for CDC and NIH? And I think it was a combination of $3.58 billion and then another $658 million, if my numbers are correct, for the NIH. Don't you think that was not responsible in light of the fact that you had the backdrop of the issues dealing with the coronavirus?
Well, NIH is the largest element of our proposed budget in discretionary spending. So it is, and by far. So in operating within the budgetary environment that we have, we had to approach it with the point of view of prioritizing the areas that that NIH wanted to prioritize, things like artificial intelligence and other areas that they were standing forward. But it is the largest element of a discretionary funding. When we're in a situation where we have to give thoughtful reforms to our discretionary budget lines, NIH as the largest element naturally ends up with some reductions. But with regard to infectious disease, we have definitely already, in that environment, we're already increasing the funding for the elements of CDC that would provide response.
My time is running quickly. Let me ask this question. Again, life expectancy before the passage of the Medicare legislation was 70 years, and after that, 72 years and growing. What came over the administration to have a $1.7 trillion, I think that's the number, cut in Medicare and Medicaid? And the president made a very loud proclamation as he was running that he was prepared to work very hard to help with the decreasing of prescription drug costs. We've seen no efforts on behalf of the president at this time and HHS to do so, and they're certainly not advocating for H.R. 3. What is your reason for the huge cuts that will go to my constituents and others across the nation in Medicare and Medicaid, and as well, doing nothing about lowering the cost of prescription drugs?
We are projecting increases every year in Medicare and Medicaid in dollars spent in these programs every single year.
I'm sorry, I didn't hear that. What did you say?
We are projecting increases in dollars spent in Medicare and Medicaid every single year, including the upcoming year and every year for the next 10 years within the budget cycle. What we have proposed is what we hope are thoughtful decreases in the rates of growth of both of these programs so that they don't grow as quickly. Part of that is what we want to do to make sure that the promise of these programs that we all agree on, Medicare and Medicaid, are available to future generations of Americans. We don't want the Medicare Trust Fund to run out in 6 years as is projected. We want it to be available. We believe on current projections we'll get 25 years out of the Medicare Trust Fund. So at some point we have to do
Can you move to the prescription drugs inactivity?
Sure. Part of the way that we've tried to reduce the cost of drugs is actually internal to the administration by increasing the number of generic drug approvals that lowers the cost of drugs overall. The more generics we have out there, the more Americans have access to generic drugs that are far lower in cost. We also have increases in the number of innovator drugs that compete with existing drugs out there. So those also help reduce the cost there. We have the drug pricing blueprint has dozens of proposals that the administration has stood forth or is planning to stand forth to reduce the cost of drugs. It is a centerpiece of what the president wants to do for Americans, and we look forward to working with Congress on a bipartisan, bicameral basis to bring forward legislation that addresses this issue. We agree with you. It is a top issue of mind.
Chairman, I just have a question. I know my time is ended. I just want to ensure that we can dig deep in the $1.7 trillion cut and why there's been no direct response to the legislation that has been offered by this Congress on lowering prescription drugs.
Duly noted. The gentlewoman's
Yield
time has
back. Thank
expired. Now recognize the gentleman from Texas, Mr. Roy, for 5 minutes.
I thank the chairman very much. Mr. Hargan, thanks for being here. The reason there's been no response to H.R. 3 is because it would devastate innovation. It would destroy the ability of the market to produce the drugs that are saving lives throughout the country, including the drug, for example, that helped save my life when I was going through cancer at MD Anderson. I think that we want to make sure we promote a market where we can have the kinds of drugs that are saving lives and not destroy it, which is exactly what H.R. 3 would do. With respect to spending, I would like to ask you to repeat again, is there a single decrease in Medicare or Medicaid expenditures in the proposed budget from the President of the United States?
There are increases in
Correct.
Medicare and Medicaid every year in the proposed budget.
Thank you. And can you tell me the amount that is proposed for CDC spending in the House Democrats' proposed budget?
I don't know that I have seen a proposed budget.
You haven't seen a proposed budget from House Democrats? Yeah, that's what I think. There is no proposed budget from my House Democrat colleagues. They want to take pot shots at the president's budget when the budget proposed by the president is increasing spending on Medicare and Medicaid, yet will not do the hard work of putting pen to paper to actually put forward a budget. That's the reality of what we're dealing with here in this room today. And so with respect to the president's budget, and we're talking about savings. You're talking about spending going up on Medicare and Medicaid. Now, why is this a problem? Healthcare costs are significantly driving our deficit spending. Would you agree?
Yes.
So 2019, we had $1.25 trillion in Medicare, Medicaid, CHIP, healthcare spending. Proposals I've seen, or projections I've seen, 2030, we'd have $2.5 trillion of that same spending. Does that sound right to you?
I'd have to look the numbers over, but yes, the numbers are enormous.
It's a massive increase going up. In 1970, mandatory health care spending was 0.8% of GDP. In 2020, it is 5.4%. In 2030, it's projected to be 7% of GDP. We have to have serious proposals in this body to deal with these issues, and I appreciate that the president and HHS has put forward a budget that tries to approach balance, even though it assumes 3% economic growth and low interest rates, but you have to have strong economic growth in order to drive out of this. Yet right now, what we have is a bunch of political shots being taken in this committee for no value for the American taxpayer, for no value for our American citizens. We're not sitting down and rolling our sleeves up to figure out what to do about Medicare and Medicaid. We're on a train heading to a cliff, and we all know it. Yet we sit here and do nothing about it. And my Democratic colleagues refuse to put forward a budget and take pot shots at the president's budget, which balances, increases dollars for Medicare and Medicaid, and then has cost savings. So let's talk about the cost savings. GAO just had a report. that came out the other day about $175 billion of improper payments, of which $103.6 billion were for Medicare and Medicaid. Are those the kinds of savings you are looking to try to achieve to keep overall spending down, but yet preserve Medicare and Medicaid?
Yes, we're looking at improper payments, waste, fraud, and abuse broadly across our programs. That's an important element of this for us to be able to reform these programs.
One thing I'd like to point out with respect to pre-existing conditions, somebody was making a comment earlier about how the president doesn't seem to be concerned about pre-existing conditions. You answered that question, I think, appropriately. I would note that I saw a report today and social media that investors see the bump in Vice President Biden as stability. And that we wouldn't necessarily get Medicare for all. But here was the little important footnote, that it will keep insurance and pharmaceutical stocks fat. Because what Obamacare really is and what the ACA really is the make insurance companies richer bill. It's keep allowing insurance companies to run our health care. Because that's what Obamacare is really doing, shoving millions of people on Medicaid, putting more decision-making in the hands of insurance companies to run our health care, and then everybody pat themselves on the back while they drove people out of the individual market, increased prices 60% across the market, double, triple the premiums for people in the individual market. That is the legacy of Obamacare. That is the legacy of putting more power in the hands of the federal government deciding health care decisions. Mr. Secretary, let me just make one point about the coronavirus, if you would. I had a great conversation over at ASPR with Secretary Kadlec, but I did have one troubling, I represent San Antonio, and one troubling takeaway from our conversations, but I saw no plan on what to do with the citizens who were flown to San Antonio. In other words, there was an assumption by DOD and HHS that citizens that were flown to San Antonio into the bases at Laughlin would then be put into civilian hospitals in San Antonio. Then we had the CDC release an individual who we know who had been exposed and had exhibited symptoms and had tested positive and was prematurely released, endangering some of the citizens of San Antonio. Can you please offer me some assurances that we're on top of this, that CDC will not make an error like that again, and most importantly, that the citizens of San Antonio will be consulted prior to decisions being made about how people are going to be released into our communities?
So with regard to the CDC protocols, they've looked at that particular case where they had followed the existing protocols, which said that you have to have, the existing amount of time be spent in the quarantine, plus there were 2 negative tests. She had received 2 negative tests, but there was a pending test outstanding. They hadn't been sequential. So she was released. It turns out that positive test was not, I don't believe it was accurate, and so there wasn't a problem, as it turned out to be. However, they have revised their protocols so that the negative tests will now be sequential, and then also if there's a pending test, that somebody won't be released until that pending test result is received. So that should manage us around the particular issue that was received there. So other than that, the protocol was followed. Globally agreed 14 days of quarantine for the people who came over. With regard to the use of the DOD facilities, I spoke myself to the mayor, also to some of the local leaders in San Antonio to talk through whatever concerns that they had. So we've been trying to do outreach to local leaders, whether it's senators, city councilmen, local leaders of any kind, and we're going to continue to do that. We're also talking to congressmen and senators of places where there are. But as we move into the next phase of what we're going to be dealing with coronavirus, I don't know that we're going to anticipate the same kinds of issues that you're pointing out there with regard to the bases.
Mr. Chairman, with your indulgence, I just want to thank the Secretary and thank you for your responsiveness generally to HHS. I can't say the same about DOD, by the way. Secretary Esper, if you're listening, I'm still waiting on a response. But thank you for that input. Thank you for reaching out to San Antonio. Just keep in mind it's important to have that plan ahead of time to know, don't assume we're going to put them in civilian hospitals. San Antonio is happy to be at the center of trying to deal with national emergencies and help our fellow American citizens. Bring them to Laughlin, that's great. But let's just have a conversation if we're going to assume they're going to civilian hospitals. Thank you, Mr. Chairman.
Gentleman's time has expired. Now recognize the gentleman from California, Mr. Khanna, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. My district in Santa Clara County, California, has 11 cases now of coronavirus. And so I want to ask you a few questions to see how we can work together to solve this. That's the only thing that people care about. First, I'm concerned that CDC has stopped reporting the number of tests they're doing on their website. Do you know why that is? And can we get CDC to start reporting on their website again the total number of testing?
Well, I think that with the dispersal of testing to a lot of public health labs, and also the fact that we foresee an availability, as Commissioner Hahn has said, of a large number of tests being available from the private sector, we think that there are going to be a lot more testing going on with that particular.
But can we just have them report? I mean, we're the United States of America, not China. We believe in transparency and getting the facts out. Can we just make sure CDC is actually reporting the number of tests they're doing and all the information they have?
Work with CDC about exactly what they're bringing forward.
Thank you. If you could talk to them about the reporting. The second thing I don't understand, again, because we're the United States of America, is how have we only done 472 tests while South Korea has done 100,000 tests already, and Italy 23,000? I mean, we are the most innovative nation in the world. We have the most resources. How do we make sure that we're getting tests out there and leading in this?
In this case, there has been no backlog in terms of tests presented to CDC. So that's the good side, that we have not had backlogs. The number of tests, there have not been any delays in terms of tests being presented to CDC or backlogs of any kind. With regard to that, before the end of this week, as CDC has indicated, we should have public health labs throughout the country. We'll have those tests available, FDA-approved tests to get out there more broadly, locally. So that was as of last Friday. And as I said, Commissioner Hahn, working with private sector, believes that there will be many, many more.
Can we set a goal that we should be the #1 country in having more tests than any other country? I mean, it seems absurd that we couldn't lead in that.
I believe by Friday, we will see a substantial uptick in that. In many cases, what we also have to make sure is that we have accurate testing, that we make sure that, and CDC work closely with FDA to make sure that our tests were accurate.
And is there a reason we're not using the WHO test, the World Health Organization, that so many other countries are using?
Well, WHO is often relied on by countries that don't otherwise have resources in this area.
Sure.
So many times, we or countries will have our own tests for these particular.
But I mean, in this case, I mean, my view is we should just get the tests out there. Can we explore if that is something we should do? I mean, I agree we should be building our own tests, but if we can test more people, why not use that?
Well, we'll definitely take that back to CDC.
Great. The other issue is, can we assure people that the testing and the treatment will be free for anything related to the coronavirus?
I think when we get, for example, with regard to vaccines, our scientists have developed some of the intellectual property underlying the vaccines, and we will be negotiating with any private.
What about, I just see my time, what about the testing for coronavirus? If you want to get a test, you should have it free. If you want to get treated for coronavirus, that should be free.
I think if Congress intends to put that kind of that into the supplemental, we'll work with them.
Would you support something like that?
We'll work with all the particularities of exactly how Congress wants to do that funding. I'm assuming you all would have discussions amongst yourselves about how you would like to.
Do you think that may be a good idea?
Provide funding on that area. I'm not going to sort of second guess Congress on how you decide to allocate resources, whether it's to testing, vaccines, surveillance, personal protective equipment, therapeutics. We've got a lot of proposals on there, state and local support for responses. So there are a lot of elements to go into that. So I think we look forward to working with you all.
And my final question, just because of my time, I ran in actually at a coffee shop to Dr. Sanjay Gupta, and he raised an important point. He said that there are only 64 to 70,000 ventilators across the country, and that we may need more, especially as this is affecting the elderly. Has there been some concerted effort to make sure we're getting more ventilators in our hospitals and public facilities?
Yes, we've been talking extensively with the manufacturers of masks and ventilators to increase supply of them and other personal protective equipment.
If you could keep Congress apprised of what we're doing to get more ventilators across the country, that would be great.
Understood.
Thank you.
The gentleman's time has expired. I now recognize the gentleman from Oklahoma, Mr. Hearn, for 5 minutes.
Mr. Chairman, thank you. It's good to be here. I always find it interesting that we have these hearings talking about somebody else's budget when we haven't done our own. By the end of next week, I'll be in 7 different hearings across 3 different committees talking about the president's budget, and yet we have yet to create a budget. These hearings often do is just, I heard my colleagues say, they start questioning the integrity of other agencies as opposed to trying to find the underlying reason why we have not produced a budget. Maybe if we produced a budget, we could spend all this energy that we've been spending in Congress reconciling the differences between the president's budget and our budget and having a real fight over ideology as opposed to an ideology of having no values regarding a budget. So it's fascinating. You know, the speaker often talks about the president destroying the Constitution, yet one of our fundamental constitutional duties is to produce a budget. First, it's the first clause of the enumerated powers, and yet we have not done it. There's no intention to do one because that would show the true underlying integrity of the values of the Democrat Party. And, you know, it's very frustrating. It's very frustrating for people who call my office that know I'm on the Budget Committee and ask the question, why aren't the Democrats putting a budget on the floor? We didn't do it last year. We did pass it out of this committee last year. I'll give the chairman credit for that. But we didn't even pass it on the floor. And this year, we're not even going to do that. So it's very troubling. And for my colleagues across the aisle to disregard that as a constitutional duty of their office to be on this committee is just dumbfounding. You know, right now, the Medicaid trust fund is going to be out of business in 6 years. We've got to get after real structural changes to that to understand how we're going to keep our accountability and our responsibility to those who paid into that fund. And quite frankly, the true word of entitlement comes. If I give you money, which I've paid in my entire life, as everybody else in this room has, I'm entitled to get that service back to me. And we're not going to be able to do that because we've rated those funds over the years. We haven't kept up with the pace of our aging population and the soaring cost of health care in America. Deputy, I could go on forever and ever talking about these fundamental failures in Congress. They're really good at blaming other people because that sells well back in the district for their races that are coming up this year. But I want to ask you some questions about the underlying things that you can tell us about President Trump's position on America's health care. Where's the president at on pre-existing conditions?
President, it's a centerpiece of what we're doing is making sure that Americans with pre-existing conditions are protected.
So he said that in State of the Union. It's been said numerous times. The leader of the Republican Party has said it numerous times. You just said it again. I assure you that the left-wing media will not ever report that it's going to be a centerpiece. They're going to still say it's not true. Could you also help me understand how, just talk about what's going to be in that budget. What's it look like for Medicare, the prescription drug costs, changing premium deductibles, co-pays, or co-insurance?
Right. So with regard to what we're doing on Medicare and Medicaid, what we're proposing is, in some cases, taking out payments that have been allocated to Medicare historically, like graduate medical education and DSH funding, that really we don't think belongs in being paid for by America's seniors. It really needs to be an item that's outside, not being paid for by the Medicare Trust Fund. That means that that trust fund is now going to be dedicated to the programs that people have paid into that trust fund, as you pointed out. We're also trying to slow the rate of growth of the programs. That's not cutting the programs, but slowing the rate of growth. We think between the reforms that we've got 25 years left in the trust fund with these reforms. We believe that these reforms, something like this has to be enacted at some point to save these programs for the future.
Can I stop you right there just because of time? Have the Democrats sent any proposal this year for just how we're going to save Medicare? It would be in their budget, right? How they're going to do that?
I have not, I'm not aware of a...
Okay, I just want to make sure we got that on the record. Are there any things that are in the proposal this year that are the same as President Obama had in his proposals as well?
We do propose, in terms of what President Obama said, yeah, we continue to sort of, as I say, keep forward Medicare, Medicaid, the regular parts of our budget that have gone on administration after administration.
I think the Medicare increase was 6% or something. Is that?
Yeah, and we're proposing, it's still a relatively, we anticipate Americans' wage growth is about 3% per year. That's about matching what we're proposing for Medicaid, and the Medicare proposal is higher than that.
Okay. Mr. Chairman, thank you. I yield back.
A gentleman's time has expired, and I now recognize the acting ranking member for 10 minutes. The gentleman from Georgia, Mr. Woodall.
Yeah, I appreciate the acting title, Mr. Chairman. I know Deputy Secretary Hargan is familiar with the acting title, and it conveys all the same responsibilities, just without any of the credit. I wanted to talk a little bit about where Mr. Khanna left off, Mr. Hargan. I think about the conflicting responsibilities you all have to actually be thinking ahead about ventilators, about masks, about not what's happening right now, but what's going to happen 12 months now, 18 months from now. And then you also have a committee of 435 on the House side that wants to know what's going on. We may not be thinking about what's going on 18 months from now. We're thinking about what our constituents called us about yesterday. And so we're asking you to do all of this planning that you're absolutely doing so well. And we're also putting additional reporting and attendance requirements in along the way. I don't want you to have to throw anybody under the bus, but is that a manageable load? We are in crisis right now. You all are responding to something that I've not seen that level of response to in my lifetime, and it seems as if the demands that Congress is making of you are rising instead of falling during that time.
Well, we have emergency response functions that are animated when these kind of things happen. We have been preparing with Congress's resources for the past 2 decades of giving money through the Hospital Preparedness Program, through our PrEP money that's given by CDC to states and localities, and through exercises that go on every year between our preparedness and response people at HHS and their state and local partners. The most recent one was in August of 2019 called Crimson Contagion that dealt with an outbreak of epidemic disease. So there's both been money, over about 2/3 of $1 billion that's spent every year on CDC for the money that's laid out for preparedness. So we have a strong public health infrastructure to deal with preparedness and response. Now, in the case of this outbreak, as we would also anticipate, the administration came forward last week, 10 days ago, with a supplemental. So we had asked for $2.5 billion. We understand that there's a possibility of Congress raising that number substantially above that. As the President said, we're open to that. We're happy to receive whatever funds that Congress sees fit to allocate to us. We look forward to working on that or any authorities or resources that Congress sees fit to give us to deal with this particular issue.
Well, I appreciate that recognition. Mr. Khan asked whether or not you believe these tests should be free and whether the treatment should be free. Constitution doesn't give you the responsibility or even the opportunity to decide how money gets spent in this country. That responsibility lies specifically with us here on the Budget Committee, but certainly across the 435 of us collectively. And if there's going to be free health care in this country, it's going to be because Congress passes a law that makes that the case. I would tell you I've been paying my health care premiums for the last 30 years, and thankfully I've not had to rely on that health care infrastructure. I don't need you to provide me with free care. I want my insurance company to provide me with free care because I've been paying them for that just in case. I know there are going to be other families that need those dollars, and I think it would be a terrible waste to blanket the country with free benefits, target those benefits to the families that need them most. I know that's what you have to do every day in terms of prioritizing. It is hard to pass budgets. I've been on the Budget Committee since I came to Congress, and we've had to twist Republican arms. Every single year, Republicans got a budget passed because it's hard to put something out there to let somebody shoot at. I cannot tell you how much I value that is a requirement that the law places on the administration, and in an area as sensitive as yours, you all and the President stepped up to the task to make that happen. I appreciate you standing up for the fact that reductions in the rate of growth are not cuts in benefits to folks. A Medicaid program, as you know, we've been working on a block grant for Medicaid in Congress for quite some time. In so many states, the only health insurance program in the state that doesn't dissuade people from attending the emergency room instead of their primary care physician is the Medicaid program. And to the extent that I'm able to move a family out of the emergency room and into a relationship with a primary care physician, I'm saving money for the taxpayer, no doubt, but I'm not cutting benefits to that family. I'm adding value to that family by moving them out of the ER where care is sporadic and into that relational care that a primary care physician can provide. So I know it's an easy line of attack that you'll hear again and again and again, and I thank you for hopefully, if we say the truth often enough, every year there's an increase in spending, then we will have some breakthrough. The chairman knows what I know, which is if we don't turn the corner on federal spending and federal revenues and the inequality between the two, we're going to crowd out all the spending. Forget whether or not you want the CDC spending to go up or go down. It's going to get crowded out to zero, and there won't be anything you can do about it. I'm anxious for us to take on some of those challenges, and I appreciate your efforts, particularly in the Medicaid program, to do that. But because we've talked so much about cuts, I want to talk about some of the really great news. CDC is just south of me in Georgia. We're tremendously proud of what they do. It's not lost on me that when they rescued Congress from the anthrax outbreak tail end of 2 decades ago, their spending rose dramatically after that. Their campus became much more attractive after they rescued us. You don't realize who you need often until it's too late, and that continual investment that you talked about year after year of the administration is meaningful to me. But let's talk about the opioid program for a second. I know you made over $150 million in new resources available there. Is there something in particular that you were targeting those for? Or again, different communities have different needs. You want to make sure additional resources are available?
Yep. So, this has been one of the signatures for this administration was the President's early recognition of the fact that the opioids crisis had to be dealt with in the United States. It is an area where we've seen last year the very first downturn in 20 years in drug overdose deaths by over 4%. That's still far too high. But it does mean that the tremendous amount of support and resources and authorities that Congress has given us over the past few years are being put to good use. We're finally starting to see some real effect in the United States, particularly in the hardest hit communities, on rural inner city communities that have been devastated by this. I mean, we saw 3 years of lowered life expectancy for Americans overall. Our last year, we finally saw an uptick for the first time in 4 years, but we had not seen a downturn in life expectancy, and the real change was the change in drug overdose deaths. So we've seen success here in the state opioid response grants that are provided to states, to tribal areas that are really starting to affect what they can do, particularly the huge uptake in medication-assisted treatment that we've been working on. So we've seen an increase in people getting medication in naloxone and other medications that are allowing them to get real treatment to survive the drug overdose deaths. There's more to it than that. There are many elements of this, including how we treat pain, revising how opioids are prescribed, looking at surveillance, making sure that doctors know whether a patient is getting prescription drugs from many different sources, increasing the cooperation between different elements, between us and the federal government, the states, the localities, social services on one side, and many elements that deal with people who are afflicted by opioids. So we've got a long way to go. We're coming down from historic levels of drug overdose deaths, so we don't regard this as the end of the road at all, but really the beginning.
Well, that's something that 435 members of Congress share in support of. Another program like that, I think you're in your second year of the Ending HIV initiative. Not treat it, not survive it, end it with another big plus up in funding. Could you talk about that?
So we proposed a really large increase this year, hundreds of millions of dollars increase for the Ending HIV epidemic. So we're in year 2. The first year was really spent on some intensive planning, on intensive preparation among the localities. We've targeted the highest number of where the continuing infections are happening. 57 jurisdictions going to be moving into those eventually, because our public health experts think that we now have technologically through certain medications the ability to suppress the virus, to prevent its transmission. That will eventually cause no more transmission. That means no more new infections with HIV. We believe technologically we can get there. Congress did gave us great resources last year. I think we achieved what we wanted to achieve last year in terms of like planning and preparation for what we're going to do and starting the work. I think now we're looking at year 2, we're looking at a substantial increase in that amount because now we're going to be moving into implementation of the plan. But hopefully by 2030, we're going to see starting the real end of this epidemic.
Mr. Chairman, it would make your job easier if we had more of an opportunity to celebrate those kinds of shared successes. When you think about budgets, you think about everything we disagree about, and we could have gone on and on. We could go on to maternal mortality rates and a pilot project that they're now expanding to 50 states, things that you and I support, that all of our colleagues support, and sadly, most of the microphone time gets spent on those things that divide us instead of that unite us. So thank you for having this hearing and an opportunity to talk about those things that bring us all together. Thank you for your service, Deputy Secretary.
Thank you, Congressman.
Absolutely. The gentleman's time has expired. I now yield myself 10 minutes. Once again, Deputy Secretary, thank you for being here. Thank you for your responses. And thank all my colleagues for their contributions. I want to clarify one thing for the record that Mr. Roy mentioned, because he mentioned that the president's budget, this has nothing to do with your specific department, but the president's budget came to balance. Yes, it does in the 15th year. He had to go 15 years to get it to balance. And make growth assumptions of 3% a year, which are far in excess of what virtually anyone else projects. And in the course of doing that, runs deficits of over $1 trillion for the rest of this decade. So it's a little bit disingenuous, I think, to say that this the president's balance is in budget. But I want to turn to the issue of what is a cut. It's gotten a lot of attention today. It got attention during the discussion we had with the director of OMB a few weeks ago. And I have to smile a little bit to myself when I hear this discussion because, and this is not directed at anybody on this side of the room, because nobody was here in 2010 when we discussed, when we drafted and passed the Affordable Care Act. But I remember very vividly in the fall of 2010, leading up to the campaign, when Republican after Republican in their campaigns talked about how Democrats were cutting $700 billion out of Medicare. $700 billion. I can't imagine how many millions of dollars were spent making that attack on Democrats, congressional Democrats in 2010. And we said the same thing. We said, we're not making cuts, we're reducing payments to providers. But on the other hand, we added services, free checkups every year, a variety of other additional services that seniors had not gotten, and we raised revenue. We imposed a provider tax. So while we cut providers in one area, we said, including DME, that's come up today, 3.8% tax. Everybody ought to contribute to the cost of this program. So when I see, we can argue whether lower costs, lower rates of growth are cuts or not. We know that roughly 1.5 million people, additional people on net, join the Medicare beneficiary ranks every year. So it's not just the cost of the care, the general inflation of the care going up, it's also the population is growing. Over the next 12 years, it grows by 18 million people projected. So yeah, obviously, again, we can run the numbers on that and we can fight over whether lower growth amounts to a cut or not. But again, 10 years ago, there was a lot of hand-wringing over that same issue. And so I will ask you, Mr. Hargan, does the president propose any additional services to Medicare in the budget?
So there are increases, for example, the telehealth services that we talked about. So with regard to rural providers, So we think that there are areas where expansion of these things is possible, for example, and also, as I mentioned, about colonoscopies. So in that area, so that people aren't sort of surprised by having a polyp removed and then getting a bill that will sort of, while they're in the middle of it doing the best practice, the doctor does it, and then a bill shows up at the end. So we're proposing to reform that area as well. So there are areas where we are proposing, where we think there are limited areas where we can provide extra benefit.
Those are services, generally speaking, across the entire healthcare spectrum, not necessarily targeted to Medicare beneficiaries, right?
And these are areas, though,
I mean, they
where
might
if
benefit
we
from
eliminate coinsurance, for example, for colonoscopies, that's definitely in Medicare. We're proposing extending coverage of immunosuppressive drugs with regard to transplants. So now, whether that may result in a savings over time, because if they're applied, you result in potentially fewer hospitalizations and increased care later. But it's going to be a extra coverage for something. So there are areas where we have proposed increases in coverage compared to what we have now.
Does the president's budget propose any increased revenues to the Medicare program?
Well, I think that we would look to the revenue side rather than the budget side for this in terms of increased revenues.
So let me segue into the conversation you had about pre-existing conditions, because this also intrigues me. I have challenged my colleagues on many occasions to tell me exactly how you protect pre-existing conditions without either the Affordable Care Act or Medicare or Medicaid. How can you preserve pre-existing conditions in the private insurance market without, well, I just ask you, how can you do it differently than the Affordable Care Act attempted to do it?
I think Congress had put forward a number of proposals over the past few years dealing with pre-existing conditions.
Congress has put forth proposals to guarantee issue. But Congress, to my knowledge, has never put forth a proposal where you have guaranteed issue and also affordability concerns. In other words, you can force insurance companies to sell anybody a policy, but if you're not going to regulate the price, then you haven't really protected them. Is that correct?
Well, I mean, as you know, the existing law, ACA, produces some of those.
Exactly, outside the ACA. And so, again, it's just perplexing to me, and this is where we were back in the repeal and replace debate, which we went through for 8 years. It was like, okay, well, how are you going to replace it? And there was never a proposal. And the reason there was never a proposal was because the only way to replace it, with anything that makes sense, is universal health care, Medicare for all, or some version of it. And my colleagues knew that, and that's why I'm sure they were absolutely relieved when John McCain put thumbs down on the Senate floor, because they would have had to come up with a proposal, and they didn't have a way to do that. I want to go also now, and this is related, on the question of prescription drug prices. You said, and I appreciate it very much, that you stand willing to work with Congress to come up with a solution. So the House of Representatives, under a Democratic majority, passed a bill, H.R. 3. Administration doesn't support it. Republicans in the Senate don't like it because they refused to take it up. So what is the responsibility? If you say you're willing to work with us, we've put forth a proposal. Don't you think either the administration or Republicans in the Senate have an obligation to work with us, if they don't like our proposal, to come up with an alternative or some amendment of ours, some modification of H.R. 3 to do with that?
Well,
it's not, I mean, I appreciate your willingness to work with us, but don't you have responsibility to advance some ideas of your own?
Well, I'd say that we have articulated at least 4 principles that I think would be broadly acceptable, which is that lowering list prices, lowering patient out-of-pocket costs, improving competition, and creating better conditions for negotiation. Those are the priorities, high level, that we've talked about in terms of drug pricing, which we think would fix it. I mean, we've seen a number of bills that have been proposed on both sides, in the House and in the Senate. Now, the question of reconciling the congressional bills, I think we would look to the Congress to move those forward, and we look forward to working with you, providing whatever technical assistance or advice that we can as you all work through preparing, as we say, a bipartisan, bicameral solution. We do have, as I say, a deep bank of experts within HHS who we would make available to anyone working on bills. And we, as I say, we have an articulated set of principles, and the president is 100% behind this goal, and we are at HHS. We know it is the articulated concern for Americans to bring down drug costs, and so if we can do that, I think that's going to be good for everyone.
Yeah, you know, I think everybody here would agree with the principles that you put forward. Those are kind of, okay, that's motherhood and apple pie. We can accept those. But if the Senate's not going to act, and the problem exists, and the American people are paying the price every day, don't you think that the administration, not necessarily HHS, but at least the White House, has an obligation to lead in this area? If we've tried to do our part in the House, Senate has refused to act, I just contend that the White House and the administration have an obligation to lead on this issue and not just say we'd be willing to work with you, because that's not move the ball forward an inch. And my time is about to expire. I just have one quick question on coronavirus. Is there a modeling done that would indicate the range of possibilities for transmission of this disease? And if so, why shouldn't the American people have the range of possibilities?
Well,
have you modeled yet what the kind of extreme possibilities might be?
So I know that there are disease spreading models that have been out in public, frankly, for dealing with infectious disease, and a lot of those have been exercised in the past, actually in accordance with some of the preparedness work that has been done in the past. So be happy to share that with you and talk through with people exactly how those kind of things are arrived at.
I appreciate that, and I know there's a potential for alarming the public unnecessarily, and you don't want to do that, but again, I think the public does have, the right to understand how little this could spread or how much it could spread. But anyway, I appreciate your cooperation. We'll work with you on that. And once again, I thank you for your appearance here today and all of your responses. And unless there's any further business, this hearing is adjourned.
Thank you, Chairman. Thank you, Congressman.